so hesitant because he would go into the hospital, but it's not like he has like a separate wing. Like those nurses have all their other patients, and then they have Jack. And I don't know if there was a comprehensive team, and I almost feel like a separate facility, as expensive as that might be, I would feel better as far as like studies.
So I'm going to repeat the question so as everyone else can hear. The question is that what about new studies of new drugs and different things that are happening in hyperinsulinism? How safe are they? Should we be doing them? And where should we be doing them? Is that a good summary?
Yes.
So the answer is that you guys are in a very difficult position because this is a very rare disease. There are only, as I said, about 100 babies a year in the United States who are born with this condition. And if you think about right now, with all the technology and everything we've done, how did we get that? How did we get to there? Well, we got to there because people in the 1990s signed up to research studies and said, yes, I'm willing to take the chance that if you put a catheter in my baby's leg and run the risk of a clot in the leg and run the risk of low blood sugars, that you might be able to find the focal lesion and operate on it. And so if the first person hadn't done it, then the second person wouldn't have done it. So research is absolutely critical to where we are now and where we are going. And you know, remember, the first person that went on diazoxide, that was research. The first person that went on octreotide was research. The first person that got Diarol or nifedipine, this was research. And so when you go to major centers, they are going to be at the cutting edge of research. So if you look at all of the papers that are published on hyperinsulinism, not all, but probably 75 to 80% of them come from a specific group of people. So all the genetic stuff, lots of it's coming out of England and in Philadelphia, and then occasionally an endocrinologist in Oklahoma will have a really unusual patient and talk to the major centers and work with them and do some testing. So every so often you get individual doctors around the country who are very clever and brilliant, just don't have all the support around them, who notice something different about one of their patients, and so talk to other people and research occurs on that patient and something new is discovered. But in terms of therapies, typically you're going to get research on therapies in big centers, multidisciplinary teams where you have all the support staff, usually at major academic centers. So in the United States, of course, Philadelphia CHOP is the absolute #1 in research in hyperinsulinism. We're hoping to be following them shortly. But they're doing some really interesting studies on some new drugs. And if these new drugs are discovered to work, then that's really going to help everyone in the 2015s and the 2020s. And those people are going to be coming to family meetings and saying, you know, well, like, haven't you always had this wonderful drug? What are they all talking about? And so yes, there are risks because it's called experiments because you don't know what's going to happen. And so what you really have to do is talk with your doctors who are asking you to participate in research, have them explain to you in as best detail as you can understand what the nature of the drug is, how they think it's going to work, and then you have to make a decision. But you've got to remember that not only are you looking at your child and what will happen to your child, but you're talking about a very rare disease. And you know, to get 20 kids with hyperinsulinism into a research study is very tough. And that's another reason why we like all of the families to come to the major centers, because if you do everything in ones, you're never going to make a lot of progress with the disease. So what I would say to you parents is that yes, there will always be new studies coming up. There is always an element of risk in entering into a study. You have to work with your doctors and talk with them. Most of us would never do anything to our patients, our children, that we think will harm them or we know will harm them. We're always doing a study because we believe it will work and we have reasons to believe it will work, but there is always the unknown. And so I think it's very important that as a community we say, let's support research, so people should be fundraising and channeling money into research. 2, let's advocate for research. And in the current financial times in the US and with NIH funding probably going to be cut, it's very important to keep making awareness of the disease and encouraging research. And lastly, as individuals, we must seriously consider the pros and the cons, the risks and the benefits of doing research, but really we should go into it with an open mind, thinking that we wouldn't have all the knowledge that we have now if it weren't for the families in the 1990s who were the first ones to put their hand up and say, yes, you can do this to me. And we have to thank all those families, and you'll notice that whenever someone publishes studies on hyperinsulinism, that at the bottom line they always say, we'd like to thank the families who participated, because without the families participating there is no research. There's only so much you can do in mice, and lots of work is done in mice, but you have to eventually get to humans. So what I would say in summary is go to major centers, talk with them, keep an open mind, and remember that you're looking at both what's this going to do for your child, but for the Hyperinsulinism Society as a whole. Any other questions? Yes, sir.
Question about exercise. You mentioned in your when you were speaking that one of the specific genetic defects is very rare, and that exercise causes a low blood sugar.
Yes.
In that one, isn't that across the board as well? I mean, is a normal pancreas affected by exercise? Doesn't it lower the blood sugar level in the body?
So you raise a very good point. So it is true that when you exercise, you use energy to exercise, and energy comes from ATP, and ATP is made from glucose. So when you're exercising, you're using up more energy. That means you're using up more glucose. So if any of us in this room who do not have hyperinsulinism go out and exercise, and we start off with a blood sugar of 85, it'll drop down a little bit, and then we'll kick in some other types of fuels to use. So exercise does use up glucose, and so if you've got a baby, a toddler running around with a glucose of 55, and they start exercising, they could, yes, drop down under 50, and you're in the danger zone. So it's always important when our kids are exercising, and particularly as they get older, they start playing soccer and all sorts of different sports, that we carb load them and get their blood sugars up and make sure that they're in the 80 to 90 range before they play sports. Now, if we're just talking about your little toddler running around the room as in normal daily activity, then of course our target is to keep the blood sugar above 70 at all times. Because if it dips below 70 into the 60s, no harm is going to come of the child. But the problem is if you set your target at 50 and you dip into the 40s, then that can cause trouble. So what we like to do with our hyperinsulinism kids is set that target at 70, so that if we miss the target a little bit, we're still safe. So, when your kids are playing formal sports and exercising, yes, you would carb load them to get their blood sugars up a little bit. You'd want them up into the 90 range probably. Just ordinary daytime running around, go for our normal goals of about 70.
Or just being in the sun. I've noticed, just standing outside, I feel like after he's out, even in a stroller in the hot Texas 100-degree weather, and comes back and checks his blood sugar, it's like, whoa, how did it drop so much?
Right. Well, this is the issue, and so some people say, if you have diffuse disease, why would you operate on the patient knowing that at the end of the day, that 2% of the pancreas that's left might still cause hypoglycemia, so should you not bother operating at all? And there are some physicians who believe that they can adequately control the glucose. And so in my mind, you really need your children to be able to keep their blood sugar above 70 doing their normal daily lifetime activities. So if you're having to say to your child, you've got to sit in your crib and not move, because if you move you'll drop your blood sugar, then you're not well enough controlled, and you have to be thinking about changing the therapies. Whereas if you're saying, well, my child is able to go 6 hours and then the blood sugar will start to drop, so I have to sort of feed them in the middle of the night, and when they're exercising I have to make sure they have a drink before they exercise, that's sort of consistent with normal daily living. Now, there are still some kids that you take out 98% of the pancreas and they still have to have a G button and continuous feeds. At that point in time you're doing everything you can do. But the question always is, are you on the maximum amount of medical therapy, and what can we do more or less? And the goal is to get normal daily activities with the therapy. If we can't achieve normal daily activities, we increase the therapy. If there's no more increasing in the therapy, then unfortunately, and I'm sure some of you know this, then you can't do certain things.
I have a question.
Yes, Angela.
There is a family in California. He's had 4 surgeries. In the end, they did end up removing all of the pancreas, but the body still produced insulin. Have you ever heard of that? Does anything inside grow back? Do you?
So the question is that we know of a child who has had up to 4 surgeries to remove the pancreas. The surgeons felt they had removed all of the pancreas, and yet the baby still has low blood sugars. Have we ever heard of that? And the answer is yes, we have. And in fact, we published a paper on this with Khalid Hussain in London. And I've seen a baby who actually had 3 surgeries. The first surgery did a 98% pancreatectomy, and the baby had profound hypoglycemia. So they sent the patient to Philadelphia after we looked at the histology and felt that the histology was focal, meaning they had taken out 98% of the good pancreas and they'd only left in the part of the bad pancreas. So we went in and operated and explained to the family that this baby only had 1 to 2% of the pancreas left. It is most likely we'll have to take it all out and the child will have diabetes after the surgery, but this baby couldn't even go a half an hour without eating. So we went in and we did the surgery. We were very happy with ourselves. We got the lesion out. Indeed, it was a focal lesion. And the baby came back from surgery and 3 hours later had hypoglycemia again. And we couldn't believe it. And so we went straight back in again, and Dr. Azik basically scraped every bit of tissue that he could away. And in the process, he had to take the common bile duct out and move it and reimplant it somewhere else. And when we looked at the histology, we saw that the focal lesion had infiltrated into the duodenal wall. And so there were beta cells in the duodenal wall. And so at this, we said to and this child after the 3rd operation still had hypoglycemia. So at this point in time, we made the decision we'd either have to go in and take out the duodenal wall, in other words, so we'd have to remove the duodenum and do basically what people for obesity have, which is a gastric bypass, because the food would come down to the stomach. It wouldn't go through the duodenum. It would then bypass the duodenum and go straight into the small bowel. And we felt at the time that that was too severe an operation to do to a newborn baby, so we and the family agreed not to do it. And then about 3 years later, PET scanning came out. And so in London, we popped that baby into a PET scanner, and lo and behold, the duodenal wall lit up, showing that there was infiltration. So that was a long answer to your question is, can you remove the whole of the pancreas and still have disease? And the answer is yes. And that is why the PET scanner is a little helpful, because it might be that you might see that. Now the problem is that the amount of cells in the duodenal wall are so small that if you had your whole pancreas in there, in other words pre-operatively, you probably couldn't see it, but you might be able to see that post-operatively. So if you have another baby in California, that's probably what's going on with that child.
You've explained exactly what he has just gone through. Exactly.
Yeah. So it's very, very rare, but we've seen it. The other thing that can happen is there's a thing called a Meckel's diverticulum, and so 2% of the population have this. It's sort of it's a common abnormality. It's so sort of commonly abnormal that we consider it a normal variation. So it occurs in about 2% of people, and it's a little bitty piece of extra tissue that grows out of the bowel wall that's 2 feet from the end of the small intestine. And about 50% of Meckel's diverticulum contain pancreatic beta cells, islets. And so in theory, if you had diffuse disease and you had a Meckel's diverticulum that happened to secrete insulin, you could indeed still have a problem. So there's at least 2 ways that we can imagine physiologically that would explain why that would happen. And of course the nice thing about the PET scanner is you might see that Meckel's in the PET scanner. And if you did, then you might take it out before, at the same time as you do the pancreas. Whereas we'd never have been able to find that with the old techniques that we used. So we can think of at least 2 reasons why that might happen.
Okay.
But it's very rare. Yes, sir.
Our son has had the genetic test done so that we know it's diffuse.
Mhm.
Is there any benefit to having a PET scan if you already know that? And
None whatsoever. I mean, the PET scanner is for people that we don't know if it's focal or diffuse. So the first stage is, there are two sort of pathways in which we go. We take the therapeutic pathway, which is that we start treating the babies once we've made the diagnosis of hyperinsulinism, and if they respond to diazoxide and they're able to maintain normal daily living, so in a baby that means feed every 3 to 4 hours, be able to go 6 to 8 hours overnight without feeding, and have normal blood sugars, that would be what we would call diazoxide responsive. And if you're able to do that, you don't need surgery, so you would take the medication. If you fail diazoxide, then you're almost certainly going to need surgery. Then you want to do genetic testing. If the genetic testing shows that you have 2 mutations, one from the mom and one from the dad, so we'll typically do a blood test on the baby and take blood from the parents at the same time. We send it off. In the United States, there are currently 2 commercial laboratories that can do testing, and then in Philadelphia, Dr. Stanley's lab can do testing in their own lab. But one of the commercial laboratories gets turned around in 1 to 2 weeks. So by the time you fail diazoxide therapy and you're starting to plan for surgery, you can get the genetic results back. If the genetic results say it is diffuse disease, you do not need a PET scan. That does not mean that you don't need to go to a center of excellence like Philadelphia or Cook Children's, where we have a lot of experience in operating, because it's like everything else that you do, the more you do it, the better you get. And so if you do 1 every 5 years, or if you do 5 every year, that's a huge difference. And so even with diffuse disease, if you're having your surgery, we would strongly recommend going to surgeons who are very experienced, because the surgery is complicated. There are a lot of potential complications. And the management of the post-operative child is very tricky and difficult. And so if you've got endocrinologists who are used to doing it, it turns out you can get in and out of the hospital typically much faster with an experienced team than in a team who's doing 1 every 2 to 3 years.